Hello students, welcome to this video where I will be discussing clinical biochemistry questions taken from Prep Ladder new and updated QBank 3.0. I have taken approximately 9 to 10 questions which we will be discussing. Before taking the questions, let me tell you some of the highlights of this new QBank. It is as good as it gets. So have a look at the highlights. Number first point is active guidance. It is as someone is holding your hands while you are doing the question bank. What happens that clinical questions are usually lengthy, and in this Q bank, when you mark the answer, then the keywords are highlighted so that you know that how to come to the diagnosis. Then second number point is that it has precise explanation. Then the questions are attached with treasures, and wherever required, video solutions are provided along with the questions. Then searching a question in this QBank, in this 19 subject QBank, searching a particular question is possible because each question is given a number. You can just copy the number and use it to reach to that question. Then it has more than 80% clinical questions, and integrated video solutions are provided between the subjects, and you get a chance to do questions based on system-wise demarcation. So it is as good as it gets. So in this video, let's start with the questions taken from this latest QBank. Have a look at the first question. A 6-year-old boy experienced episodes where he develops patches of skin rashes. So skin rashes is a keyword here, which go away in a week to 10 days. A pediatrician told the boy's parents to give him niacin. This is another keyword here. Niacin was given to the patient the next time this will occur, along with a high protein diet. High protein diet is also recommended. So here is something related to amino acid and proteins. Okay. So the rash resolved in a day or two when they did this. So the rash was resolved on giving niacin. This child has which of the following diseases based on this information? So this points me towards Hartnups disease, where tryptophan is getting lost in urine. When tryptophan is getting lost in urine, then these patients have amino acid urea, mainly tryptophan and other non-polar amino acids coming in urine. It is a transporter defect. There is a defect in transporter which is present in intestine as well as kidneys. So from intestine, these amino acids won't be absorbed in a proper way, and in kidneys, they won't be reabsorbed. So these will be lost in urine, mainly tryptophan. Tryptophan helps in the formation of niacin, that is vitamin B3, which is also an atypical vitamin. Okay, this can be formed from amino acid tryptophan normally, right? But when there is deficiency of tryptophan in the body in Hartnups disease, then the deficiency of niacin will occur. That is known as pellagra, where patients have photosensitive dermatitis, right? That's why this patient has this rash, and these rash were relieved after giving niacin, right? So Hartnups disease is the answer. And what is cystine urea? Cystine urea is a part of Garrod's tetrad, where this is also a transporter defect. It is also a transporter defect for dibasic amino acid, okay? So dibasic amino acids will be coming in urine. So in cystine urea, there is a mnemonic COLA. These 4 amino acids, COLA, C-O-L-A, these 4 amino acids will be coming in urine. C stands for cystine, O for ornithine, L is lysine, A is arginine. So basic amino acids and cystine and ornithine, okay? Because arginine can make ornithine, okay? Then triple H syndrome is a urea cycle defect. So here ammonia levels will be raised. Then L-Capitan Urea. In L-Capitan Urea, the enzyme deficient is homogentisate oxidase, or the new name of enzyme is homogentisate dioxygenase. Okay. So, in Capitan Urea, there is blackening of urine of the patient or diaper of the child, or there is blackening of cartilages and soft tissues and skin, right. There is nothing such written in the question, right. Ammonia level is not raised, these amino acids are not coming in urine, right. So, we have concluded our diagnosis towards Hartnups disease. Coming to the next question, maple syrup urine disease, MSUD, where patient has burnt sugar like odor in urine. It is a defect in the catabolism of branch chain amino acids, that is valine, leucine and isoleucine, due to mutation in this enzyme. Which enzyme is defective in MSUD? It is branch chain alpha keto acid dehydrogenase or decarboxylase. Both names can be used for this enzyme. This is a multi-enzyme complex. Like alpha ketoglutarate dehydrogenase of TCA cycle, this is also a multi-enzyme complex. So, all of the following are cofactors for this dehydrogenase except, be careful whenever except word is given in the question, okay. So, 5 cofactors are required for this enzyme. They are vitamin B1, that is thiamine, then FAD, NAD, coenzyme A and lipoic acid. So, these are required. Which is not required, that is the question. So, option A, FAD is required, lipoic acid is required, thiamine pyrophosphate, that is vitamin B1, that is required. So, your answer here is NADP. This enzyme does not use NADP, instead it requires NAD, right. Coming to the next question, a 45-year-old man developed severe pain in his back, which turned out to be due to kidney stones. So, one main key point here is kidney stones. The chemical analysis of stone indicated a buildup of oxalic and glyoxalic acid. So, oxalic acid written here is very, very important. Problem with which of the following amino acid metabolism can cause development of these stones? If you have read your amino acid chemistry nicely, then you are very clear with the answer. So, let us revise that. Glycine forms glyoxylate with the help of enzyme glycine oxidase, right. Then glyoxylate has 2 fates. One is it can form formate in the body. On the other hand, it will form oxalate, which is excreted in urine via kidneys obviously. Then there is one enzyme which can convert glyoxylate back to glycine. This is transaminase and that requires vitamin B6. If there is this enzyme defective, this transaminase is defective, then glyoxylate will be getting accumulated and it will be forming excess of oxalate and they can lead to, this oxalate will combine with calcium and will make kidney stones of calcium oxalate, right. So, recurrent kidney stones are usually getting formed in such patients and this is known as primary hyperoxaluria, right. And if there is vitamin B6 deficiency, then it is called secondary hyperoxaluria because that will also affect this enzyme only. Coming to next question, a patient presented to casualty with nausea and vomiting. Intravenous glucose was given and the patient recovered. After few months, patient presented with same complaints. Blood glutamine was found to be increased. So, blood glutamine is increased in urea cycle defects, in hyperammonemia. Okay. So, also uracil levels were raised. So, one they are telling that glutamine is raised, other thing is uracil levels are raised, which is a pyrimidine. Okay. So, what is the diagnosis? Whenever there is a patient picture of hyperammonemia and urea cycle defect, along with some constituents of pyrimidine pathway, they getting accumulated, then it is this enzyme OTC, ornithine transcarbamylase deficiency of urea cycle. This is also the most common urea cycle defect. So, let us see urea cycle here. So, first step of urea cycle occurs in mitochondria, where carbon dioxide and ammonia combines to make carbamoyl phosphate. Here 2 ATPs are used. Enzyme is CPS1, that is carbamoyl phosphate synthetase 1. Then second enzyme is OTC, where carbamoyl phosphate and ornithine joins to make citrulline. Then there are 3 reactions occurring in cytoplasm. First is arginosuccinate synthetase enzyme in cytoplasm, okay. Then arginosuccinate lyase, then is arginase is the last enzyme which is making this urea. On the other hand, ornithine, and ornithine goes back in mitochondria again and contributes to next cycle, okay. So now what happens when there is OTC deficiency or defect? So this enzyme OTC, if defective, then there is excess of carbamoyl phosphate in mitochondria. This excess will go in the cytoplasm. Here there is CPS2 enzyme, which is rate limiting enzyme of this pyrimidine pathway. So if there is excess of carbamoyl phosphate because of ornithine transcarbamylase defect, then these substances will be increased in patient's body, that is orotic acid, OMP, UMP, right. So whenever they tell you any of these things raised plus ammonia raised or urea cycle, hyperammonemia, clinical picture, then go for OTC defect. Coming to next question, a patient presented to OPD with complaints of weak fragile hair, and that picture is given here, weak fragile hair that easily break and hair loss. There are multiple diffused white to black colored weak points along the hair shaft. You can see that picture, right. The following image was obtained. Which of the following enzymes would most likely be deficient in the patient? So this is also a picture of urea cycle defect, and in arginosuccinate lyase deficiency there is trichorexis nodosa. So you can have a look here. The image shows beaded swellings along the hair shaft, that is friable appearance. This is trichorexis nodosa, which occurs in arginosuccinate lyase deficiency. So other clinical features of hyperammonemia, that is intellectual disability, protein aversion, lethargy, which can progress to coma also, right. Coming to next question, a newborn develops jaundice, yellow skin, yellow sclera, that requires lab evaluation. Which of the following porphyrin derivative is conjugated, reacts directly, and is a major component of bile? So the major component of bile here is bilirubin. Now in the options, bilirubin diglucuronide is also given and simple bilirubin is also written. So which one to mark? When they have given react directly means it is direct or conjugated bilirubin they are talking about, that is conjugated in liver, right. So bilirubin diglucuronide is the form or conjugated form. So this is the answer, right. Now how come it is coming from porphyrin? See, porphyrin, in the porphyrin ring, iron is added to make heme, and when heme is catabolized, then first biliverdin is formed, then bilirubin is formed, okay. So bilirubin is formed in reticuloendothelial system, then it joins albumin protein in the plasma and reaches liver. In liver this conjugation occurs and we get bilirubin diglucuronide, that is 2 glucuronic acids are attached to this bilirubin, right. Coming to next question, a 50-year-old man was initially diagnosed with acute intermittent porphyria based on high level of urinary delta amino levulinic acid. So delta ALA levels are raised in this patient and this patient was diagnosed as acute intermittent porphyria. Later, it was found that patients 70% of circulating red blood cells contains elevated level of protoporphyrin. So, they have now seen that protoporphyrin is also raised, and in fact more raised. So, the diagnosis was corrected. So, that means acute intermittent porphyria is not the correct diagnosis here. So, what is the correct diagnosis? The correct diagnosis here is lead poisoning. I'll explain you on the next page. See here, heme synthesis pathway, succinyl-CoA plus glycine, they'll join to make ALA, that is delta amino levulinic acid. Enzyme is ALA synthase, which is the rate limiting enzyme. Okay. Then there is PBG synthase and PBG, porphobilinogen, will be formed. Then there are 5 steps, and there is no need to go do the detail. Then protoporphyrin is formed, in which iron is added by ferrochelatase and heme is formed. Lead affects these two enzymes, PBG synthase and ferrochelatase. So, in lead poisoning, this compound ALA will also be raised, and this compound protoporphyrin will also be raised, right. So, the correct diagnosis of this patient is lead poisoning. Coming to next question, a 44-year-old male concerned about his risk of heart attack since his brother just had a heart attack. So, at the age of 46, right, his physician orders an HbA1c, lipid panel and homocysteine level. His blood shows high homocysteine levels. Which one of the following amino acid is not metabolized properly in the blood? So, homocysteine is an intermediate in the metabolism of which amino acid? Methionine, right? So, answer is methionine here. Homocysteine is only and only formed in this methionine cycle. And do not mark the answer as cysteine, right? Because in the body, what happens is in diet we get methionine, right? Methionine, from methionine homocysteine will be formed. From homocysteine, cysteine will be formed, right? So, here homocysteine levels are raised. So, methionine is not metabolized properly, right? Coming to next question, a 20-year-old male is new to your locality and you notice he has white hair, white skin and nystagmus. A defect in the metabolism of which one of the following compound is responsible for this? So, white hair, white skin, see it is completely white written, not patchy. If patchy hypopigmentation, then the patient has vitiligo. This is not the scenario. When it is complete white and light color, then it can be albinism, right? Or this whitening also occurs in phenylketonuria, right? But the diagnosis is more towards albinism. They have not written anything about phenylketonuria, right? And nystagmus also occurs in ocular albinism. So, the best diagnosis here is albinism, right? And the question asked is a defect in the metabolism of which of the following compounds, and the amino acids are given, right? So, you know that tyrosine is the amino acid which forms pigment melanin, and the enzyme here is tyrosinase. Defect in this enzyme leads to albinism, right? So, answer is tyrosine here, okay. Then next question, decarboxylases which use pyridoxal phosphate, that is vitamin B6 as a cofactor, catalyze breaking of carbon-carbon bond and releases carbon dioxide without using ATP. So, this is decarboxylation happening. It requires vitamin B6. So, decarboxylation of which of the following amino acid yields a potent vasodilator? So, we know this thing that histidine forms histamine by simple decarboxylation. It requires vitamin B6 and histamine is a vasodilator, right. So, answer is histidine. So you can have a look here that decarboxylation of amino acids produces amines. So these are the biogenic amines. From histidine, we get histamine. 5-hydroxytryptophan forms serotonin. Tyrosine forms tyramine. You can see amine, 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 amine here. Okay. So all these are amines. Dopa forms dopamine. Serine forms ethanolamine. So this is it with the questions. I have taken all these questions from a particular topic of the Q bank, that is amino acids and proteins, right? So this is it with the video. So enjoy this interesting new updated Prep Ladder Q bank 3.0 and best wishes to you.